in investigating, evaluating, and management of a person who has come to us with recurrent UTI. So let me share the screen. Can you see the slide?
Yeah, ma'am. Yeah, ma'am. We are able to see.
Okay. Okay. So in the whole session, what we are going to try and achieve is understand what we call and define as recurrent UTI. When do we call it an uncomplicated urinary tract infection? And what are the criteria so that we can call it a complicated UTI? When and what is asymptomatic bacteriuria? What are the risk factors in women in general who would present to us with recurrent UTI? When do you actually have to treat them? And what are the important treatment aspects? What can we do in terms of non-pharmacological prevention and pharmacological prevention? And a small intro or a small insight into the advances in management. We all know recurrent UTI is a big burden, not only physically, but also in terms of the financial burden. It's highly prevalent and affecting women of all ages and races. To put things in perspective, if you're a woman in your lifetime, in 60% of the women, like 3 in 5, will develop UTI at some stages in their lifetime. And nearly two-fifths of them will again have a repeat episode, and nearly 50% can go on to have recurrent episodes. So you can imagine that's having more than half the world population as women. This is going to incur a lot of health related economics as well as a big health burden as far as the recurrent UTI is concerned. We don't stop there. It is the injudicious use of antibiotics for the so-called presumptive recurrent UTI, which has collateral damage resulting in multi-drug resistant bacterial infection, overwhelming sepsis, related ICU admissions, critical care hospital charges, and the burden which comes along with it. Apart from that, nosocomial infections like Clostridium difficile and so on and so forth, because of the collateral damage resultant as a result of the injudicious usage of the multiple antibiotics, which we are going to see. So you need a culture proven sample to define acute bacterial cystitis in anybody with a bacterial pathogen associated with acute onset symptoms such as dysuria, frequency, urgency, and blood in urine, any new or worsening incontinence. So somebody who has had incontinence, if there is a worsening of incontinence, then we need to understand this could be related to UTI. But however, not all incontinence is related to UTI, and the antibiotics alone will not make it go away. Most of the patients who are misinterpreted or mistreated as UTI are those women with overactive bladder. They will not have dysuria. They will not have frequency. They might have urinary urgency and incontinence. That is something we need to watch out for. Can I request everybody to please mute the mic because there's a lot of disturbance?
Yeah, it's done, ma'am.
Yeah. An infection of the urinary tract in a healthy patient who has otherwise an anatomically and a functionally normal urinary tract and doesn't have any other host related risk factors is called an uncomplicated UTI. Basically, anybody who comes for the first time, I've had the first time UTI, is an uncomplicated UTI. They have a higher risk of development of a UTI and potentially decrease efficacy of the therapy. And those patients are the ones with anatomical or functional abnormality of the urinary tract, immunocompromised host, and a drug-resistant bacteria. So in these situations, when somebody develops complicated UTI, then we understand there could be an underlying problem in this host, either because of the host related immunosuppression or because of functional derangement or an anatomical abnormality or a pathological reason within the urinary tract which could result in the complicated UTI. When do we call somebody to have recurrent UTI? When the woman has two separate culture proven episodes of acute bacterial cystitis and associated symptoms within 6 months, or three episodes within one single year. We also need to differentiate between relapse and reinfection. Relapse is somebody who has bacterial persistence and somebody who has a recurrent UTI. And persistence means involving the same bacteria which has not been completely eradicated in the urine 2 weeks after sensitivity adjusted treatment. A reinfection is a recurrence with a different organism or the same organism coming back in more than 2 weeks with an intervening sterile culture. Say, for example, a woman has E. coli and she has been treated completely. Within 2 weeks after treatment, you see she's still persisting to have symptoms. I'm not saying here you do a urine culture. She's persistent to have symptoms and you do a sample testing that shows E. coli. Again, that is bacterial persistence. Probably we have not treated her with a correct sensitive bacteria or it is already resistant. Whereas a bacterial reinfection is a recurrence where instead of E. coli, you find Klebsiella or you find E. coli itself, say after a month when you have already had a sterile culture in between. So hope I'm clear about relapse and reinfection. So what is asymptomatic bacteriuria? Presence of bacteria in the urine, that's all. But the patient does not have any symptoms. Without symptoms, bacteriuria of any magnitude is considered to be only asymptomatic bacteriuria. People will argue, if the colony count is high, should I consider it as culture positive and treat it? If the woman has no symptoms, it is still considered asymptomatic bacteriuria, however the burden of bacteria in the urine be. So, for practice, patients initially treated for uncomplicated bacterial cystitis who recurred rapidly within 2 weeks of initial cyst treatment and after symptom resolution or display the persistence of the same bacteria, we should be reclassifying these patients as complicated UTI and they require imaging of the bladder as well as the upper tract, mainly to rule out a pyelonephritis or an ascending infection which has caused an abscess, and cystoscopy and further investigating for bacterial reservoirs. Very important, especially in elderly postmenopausal women where there could be difficulty in emptying of the bladder either because of a prolapse or a cystopathy because of an autonomic cystopathy if they are a diabetic patient, and or because of a dysfunctional pelvic floor disorder, which could then result in dysfunctional voiding and thereby causing recurrent urinary tract infection with bacterial persistence. So if somebody is not getting treated within the 2 weeks of the recommended sensitivity-based treatment and they have persistence and they show symptoms, you take them from the uncomplicated UTI, make them as complicated UTI and investigate further. Do not persist with repeated different bacteria and prolong the problem. So it has also been agreed as part of the Geriatric Society as well as the Infectious Diseases Society of America that evolution and treatment for suspected UTI should be reserved for anybody with acute onset within a week of fever or dysuria associated with UTI associated symptoms and signs, mainly gross hematuria, worsening urinary urgency, frequency, and incontinence, and suprapubic pain. So you need to have all the three along with fever or dysuria. So fever and dysuria will be in common. Clinicians should obtain a complete patient history and perform a pelvic examination in all women presenting with recurrent UTIs. So what do I do in terms of detailed history? I take the history of a pneumaturia, hematuria, fecaluria, bowel symptoms related to constipation, any worsening of inflammatory bowel disease, alternating constipation and diarrhea, contamination of the fecal related matter in the vagina, any recent use of antibiotics, vaginal discharge, their sexual practices, and diabetes in the spouse as well. I also specifically ask about vaginal cleansing practices, use of spermicides, contraceptives, hormonal usage, especially estrogen related, progesterone related, combined contraceptive pills, or systemic HRT, and also their menopausal status. I also specifically ask about triggers, mainly menstruation related worsening or in and around menstruation period, pad related irritation, which could be misdiagnosed as UTI, or a postcoital onset of UTI on a regular basis, whether they are using steroids or recent usage of steroids, any immunosuppressant therapy. These are all very important triggers, which could then potentiate the result of a recurrent UTI. I use a simple mnemonic during clinical examination called Werner, which gives me an complete evaluation of all the systems to look out for possible predisposing factors in the woman, which could trigger the recurrence or the bacterial persistence. I do a thorough external genitalia and vaginal examination to look out for various factors which could predispose the woman to recurrent UTI. A rectal examination, especially for anal tone and anal reflexes, very, very important. Abdominal examination for suprapubic mass, tenderness, as well as any related tumor is also very important. Neurological examination, especially to make sure we are not dealing with the neurogenic bladder or avoiding difficulty or any loss of sensation in that area, which would help us determine what could be the possible reason this woman is suffering with recurrent UTI. When the woman walks into the clinic, I assess their gait because it could be the fact that their reduced mobility or the lack of confidence in the gait due to arthritis, Parkinson's, stroke is preventing them from going to the loo on a regular basis. So they restrict their water and thereby getting recurrent UTI. When they're sitting in the chair, many women with atrophic vaginitis and dysuria, which is complained as dysuria, but actually it is the vulvodynia, especially young women with interstitial cystitis or elderly women with genitourinary menopausal syndrome, and women with lichen sclerosis and related vulval dermatosis, they usually have a very fidgety posture and are not able to sit comfortably because of the irritation down there. Vulval atrophy, excoriation, fecal contamination, any presence of intertrigo, hygiene, whether there is contamination because of the discharge from there, dermatosis gives me an idea that it could be related to a vulval disorder rather than urinary tract infection. And no matter, however, people have tried antibiotics, the woman is not going to be better from her symptoms. Vaginal suppleness, atrophy, any prolapse and widening of the genital hiatus. Prolapse of each single compartment to be quantified according to the POPQ, and also to understand whether that could be a predisposing factor. Palpation of the urethra and the bladder base, as well as the Skene's glands, will tell me if there is a diverticulum, if there is a urethral abscess, which could be the reason for the recurrent urinary tract infection. Always assess the pelvic floor muscle tone and strength and grade it according to the Oxford grading. When there is no tone or there is a flicker, when there is some tone in the muscle, when there is good elevation of the perineum and good tone and bulk of the muscle. So these are the various Oxford grading up to grade 0 to grade 5. Whether there is any incontinence as well as stress urinary incontinence, presence of anal tone and anal reflexes, which will tell me that S2 to S4 innervation is good, a thorough neurological evaluation to find out whether we are dealing possibly with a neurogenic bladder or even an autonomic neuropathy affecting the bladder as well. So, to make a diagnosis of recurrent UTI, clinicians must document positive urine cultures associated with prior symptomatic episodes. Basically, when the patient tells me, I've had UTI, do not take it with the face value. You find out whether the patient has had a urine culture, whether the patient has had a urine routine, corroborate it whether there was pyuria, look at the culture and sensitivity pattern, and then document it as bacterial cystitis, without which we cannot call the patient to have recurrent UTI. What are the other conditions which could mimic recurrent UTI and what should be aware of. Interstitial cystitis and bladder pain syndrome. This is often misdiagnosed as recurrent UTI, and patients get treated with antibiotics, which only make it worse. Interstitial cystitis is this classic triad where there is suprapubic pain, there is frequency, and urgency. Culture invariably is negative. However, a UTI could have been the trigger factor for a flare in an interstitial cystitis. There is always some relation to food triggers or food allergies. Patients also have a phenotype related to either fibromyalgia, chronic irritable bowel syndrome, or chronic depression, chronic pelvic pain, so on and so forth. They are very tender when you examine them, especially in the suprapubic region, as well as the anterior vaginal wall and the bladder base. And they can also have muscle spasms and myofascial bands in the vaginal examination, which is why a thorough vaginal examination is very, very important when you're dealing with these patients. Overactive bladder, again, there will not be any dysuria unless the woman has developed UTI because she's voluntarily restricting the water intake because she's suffering from significant urinary frequency and urgency. Genitourinary syndrome of menopause. This is the most commonly misdiagnosed, mistaken entity, and people are treated recurrently with antibiotics when actually they needed a thorough clinical examination. And you can see labial synechia because of the vaginal atrophy. You can see fissuring of the posterior fossa, obviously, which will cause not only dysuria, will cause burning even when water hits that area. Patient will not be able to sit comfortably. She will not get better at all with any amount of antibiotics unless we are going to prescribe her Premarin. She's not going to get, or estrogen cream. She's not going to get better. Urinary calculi, yeah, they can get infected, but can be mistaken for UTI as well. Infectious bacterial fungal vaginitis and vulvar dermatitis, non-infectious vulvovestibulitis, hypertonic pelvic floor muscle dysfunction typically happens in women where, because of the pelvic floor dysfunction, they keep the whole perineum tight. This causes muscle spasm. They have dysfunctional voiding and then end up in urinary tract infection. Carcinoma in situ of the bladder. The clinching point here will be the hematuria. They will be passive smokers or smokers themselves. No amount of antibiotics will get rid of the symptom. They will have sensory urgency and frequency, unabating lower urinary tract symptoms with hematuria should always be investigated with imaging and cystoscopy, and do not settle for just urinary tract infection in these patients. So you should obtain repeat urine studies when an initial urine specimen is suspect for contamination, with consideration for obtaining even a catheterized specimen. We all tell our patients go and do a clean catch midstream urinary specimen. It is very, very difficult to do so. How are we going to ensure that they are doing it? Especially our elderly, obese, diabetic women who are in their diapers and are not able to walk properly. Separating the labia might be difficult. Cleaning that area and to concentrate on the midstream catch might be difficult. So these are some things which we need to consider, and it's okay to obtain a catheterized specimen so it will be a clean catch. Having said that, we also need to understand catheterization itself might trigger off an infection, and we'll have to use it based on the weightage of the merit it will allow us to obtain a clean catch specimen. We can also understand a specimen to be not a clean catch or a contaminated specimen if the epithelial cells are more than 20. Obviously, it is vaginal contamination, and the interpretation of the results cannot be great. And you also sometimes get bacteria which are on the skin. That is definitely a contaminated specimen. So look out for typical uropathogens, look out for the non-fermenters. If you find skin pathogens, most likely the specimen is contaminated. Always obtain urine analysis, urine culture, and sensitivity with each symptomatic acute cystitis episode. Do not treat empirically. You might give the empirical treatment while awaiting the result, but do not start the treatment without sending these samples, without which we will not be wiser as to emerging resistance pattern of the multiple antibiotics which the patient might already have been subjected or exposed to. Some selected patients, you may offer initiated treatment, or you can also tell the patient self-start the treatment with acute episodes while waiting for urine culture. These are the patients where compliance will be ensured and follow-up will be ensured, not the patients who will disappear with a single dose of antibiotic once they feel a bit better. They can come back with urosepsis, pyonephric abscesses, and acute pyelonephritis and life-threatening urosepsis if they do not follow your advice particularly. Clinicians should omit surveillance urine testing, including urine culture in, say, asymptomatic patients with recurrent UTI. This is a common problem which happens irrespective of us telling the patient as well. Patients themselves take it in their own hands to do this. After the treatment is over, one single episode, they're so afraid and apprehensive they'll develop urinary infection. They do this test of cure, go and give a urine sample without even giving a urine routine, and the bacteria, some weird bacteria will grow and they will start treatment on their own. Please dissuade your patients and yourselves from prescribing urine testing, especially as a test of cure. It is not indicated. It is no matter wiser to do that if your patient is asymptomatic. However, if the patient continues to report symptoms, it's okay to give the sample. And in such cases, if you find how much ever colony burden is there, if they are asymptomatic, please refrain from treating these patients again with a course of antibiotic. It will lead on to collateral damage, other major side effects, as well as problems regarding that. Clinicians should use first-line therapy depending on the local antibiogram for the treatment of the symptomatic UTI in women, preferably nitrofurantoin and fosfomycin. This is just to show you how better the cure rate with fosfomycin and nitrofurantoin is. And fosfomycin has the advantage of covering ESBL bacteria as well. No collateral damage associated, very low resistance patterns, and a single dose where compliance can be ensured can be given in pregnant women and elderly with minimal side effects. Compliance is not a problem as it's a single dose. In patients with recurrent UTI, when associated urine cultures is resistant to major oral antibiotics, you choose to do directed parenteral antibiotics for a short course as reasonable, but only for a week, not more than that. So that is very, very important for us to know so that we don't prolong the treatment for more than 7 days. In certain patients, we have to consider prophylactic choices where we will be giving the trimethoprim once daily, or a nitrofurantoin 100 milligram once daily, or fosfomycin 3 grams every 10 days. And in pregnant patients, we circulate between nitrofurantoin and cefalexin given 250 milligram once daily. So the usual prophylactic protective course antibiotics on a low dose are for 3 to 6 months, and we can also recycle every 3 months as in pregnancy, and always review them in 6 months to see whether you need to continue or stop them completely. Do not continue them beyond a year whatsoever, because these can have far-reaching consequences. You can also advise the patients to have postcoital or even precoital antibiotic in these formats every time they have an intercourse, especially for young premenopausal women who have a flare up of UTI because of intercourse. So this is a known practice and helps in women suffering with the symptoms for long and ending up having recurrent UTI episodes. Other prophylactic measures are recommending cranberry and D-mannose. No strong evidence for routinely prescribing probiotics, but may be helpful in inflammatory bowel disease and those who have other bowel suppressants like immunosuppressants for their bowel. Increase the fluid intake for up to 1.6 to 2 liters per day. No evidence for povidone iodine instillation, herbal concoctions, biofeedback, or immunotherapy. UTI vaccine is now being explored. It's not widely available. It's still in a research setting, but seems to be promising because most of these infections, irrespective of whether we all understand they are all bacteria in our own body because UTI doesn't come from outside. And these bacteria develop resistance by the biofilm. So anything which will attack the biofilm or prevent the adherence of these bacteria to the host cells within the urinary symptoms, especially in the women due to the anatomical proximity, will help us crack into the treatment or the betterment of these patients with recurrent UTI. Definitely estrogen vaginal cream. If it is a 17 beta estradiol, it's 2 grams daily for 2 weeks and then 1 gram thrice a week. If it is the conjugated equine estrogen, it's 0.5 milligram daily for 2 weeks and then twice weekly for at least 6 months and then prolonged indefinitely with regular follow-up. Clinicians should not perform a post-treatment test of cure analysis, or urine analysis or urine culture, if especially the patient is asymptomatic. Should repeat urine cultures to guide further management when the UTI symptoms persist following the antimicrobial therapy. So encourage better hydration to ensure more frequent urination, as this can reduce recurrence. Encourage urge-initiated voiding and postcoital voiding. Advise sexually active women the diaphragm and spermicide usage are risk factors for cystitis and therefore discuss alternative contraceptive. Advise the patient to obtain and try cranberry products. Make sure they're not on warfarin because the bioavailability can change, and D-mannose to also reduce recurrence. Offer a prescription for standby antibiotic to be taken at the first symptom onset. For recurrent cystitis associated with sexual intercourse, offer trimethoprim or nitrofurantoin within 2 hours of intercourse. For postmenopausal women, definitely prescribe Premarin only as an intravaginal estrogen therapy. No systemic HRT, and review within 12 months. For postmenopausal women, where there is no obvious risk factors, you have to consider referral to a Uro-Gynaecologist or a female urologist, especially if recurrent UTI is a recent problem. So if you fail to treat the UTI properly, check the MSU to find and diagnosis and sensitivities in an acute episode. If continued problems, then do a renal tract ultrasound and a post-void bladder residual volume to find out if there is any voiding dysfunction. And also, as I said, if there is a new surgence of symptoms or a sudden aggravation in the postmenopausal women, a cystoscopy should be considered and done to rule out an intravesical lesion. If all the things are normal, then go ahead prescribing low-dose prophylactic antibiotics, maybe a D-mannose cranberry combination, and if postmenopausal, definitely a estrogen cream vaginally for at least a period of 6 months, and review the patient every 2 to 3 months if they are on long-term low-dose prophylaxis. So complicated recurrent UTI. So far, we have seen women with uncomplicated recurrent UTI. In women who get recurrent UTI, the complications they could be because of host factors as well as because of the structural and functional abnormality. If the woman has a cystocele, if there is a diverticulum or a fistula, if there is a long-term indwelling catheter, there is a voiding dysfunction, there are neurological disease or pelvic floor dysfunction, high post-void residual volume, urinary tract obstruction, bladder outlet obstruction, urethral strictures, as well as pregnancy, immunosuppression, diabetes, we should treat them as complicated recurrent UTI. And always evaluate quickly when there is a prior urinary tract surgery or trauma. Say, for example, a woman with previous TVT comes with UTI. I will not wait just with an empirical treatment. I will go ahead and do an ultrasound kidneys with a post-void residue to see whether there could be a dysfunction in voiding or bladder emptying due to obstruction due to the transvaginal tape, because that could mean a lot, and find out why this woman is being obstructed and therefore getting UTI. Gross hematuria after resolution of infection should be an indication to scope as well to find out the upper renal tract. Previous bladder or renal calculi to see if there is a recurrence or it could be something else. Obstructive symptoms because of prolapse, because of any other tumor. Low uroflowmetry or high PVR, especially in patients with abnormal bacteria, which is not the usual pathogen. When there is a bacterial persistence, even after the sensitivity targeted therapy, any prior abdominopelvic malignancy, especially if they have had chemotherapy and radiotherapy, because both of them are immunosuppressive therapies, and more so if there is pelvic radiation because of the bladder related cystopathies, bladder related radiation cystitis, as well as dysfunctional voiding, which can happen because of the fibrosis in and around the area. Diabetes or otherwise immunocompromised patients, pyelonephritis, and asymptomatic microhematuria. I'm happy to take questions now.
Yeah. Any question anybody is having, they can raise their, I think, hands, and then we can allow them to talk.